Next, over to Dr. Anjana. She is a glaucoma consultant. One more topic is there, madam. Uh, Please sit. And it is the topic is on lens assessment and bleb assessment with ASOCT.
Hello. So,
Let them enjoy.
so good evening. I'll try to make it as short and sweet as possible. So my topic, first of all, at the outset, let me thank KSOS and Dr. Jayashree for giving me this opportunity. At least I read through a lot and understood a lot about this. So I'll be dealing with the lens and bleb assessment and what else we will see as we go through. So most of the differences have been highlighted, and one thing which is pupil size is less affected by ASOCT than with UBM, and some of the important limitations about ASOCT which we need to take care is that the operator should be aware about the scan protocols and the instrumentation. Why the image is taken, they should be aware of it. Then only they can acquire a proper image. So even though it's easy, the operator should know what to take, when to take, in which position, which scan protocol to use and all to get a proper image. And the tracking between visits is found to be not very good with ASOCT, and the interpretation by the doctors also, the landmarks and all may differ sometimes. And the UBM, as already mentioned, has the advantage of penetrating the posterior pigment epithelium. In the lens assessment, the two terms which need to be known is, one is crystalline lens rise and the other one is lens vault. And as mentioned, lens vault is associated with angle closure. So I'll show this, like in the first picture, it's the angle recess to angle recess line is drawn, and the perpendicular from there to the anterior crystalline surface of the lens is a clear crystalline lens rise. And this is more used for planning phakic IOLs and all. And the second one, it's the scleral spur to scleral spur line, and the perpendicular from there to the anterior crystalline surface is the lens vault. So scleral spur, we have Dr. Sandhya has given the details about how to identify, and so it is the prominent inward extension of the sclera with a change in curvature. And it is used as a reference point to identify trabecular meshwork and iris root and all. So these pictures, both of them show same lens vault. The scleral spur line has been aligned and the lens vault is almost the same, but as we can make out, the anterior chamber depth is different. The first one is a narrow, shallow AC, and the other one has a larger anterior chamber. So even though the lens vault is a predictor for angle closure, sometimes it may not give a correct result. So anterior vault is assessed, that is actually lens vault with anterior chamber depth, and the relative lens vault, which is the lens vault in relation to the anterior vault. The relative lens vault will give a better idea of the chances of angle closure than the lens vault. So this is a study of about 100 subjects, and you can see that both the lens vault and relative lens vault are more in PSC eyes, but relative lens vault is supposed to be more reliable than the lens vault assessment. And as already mentioned, the UBM only gives the detailed evaluation of the lens up to the posterior lens capsule, which is not possible with an ISOCT. Coming to the next, that is the bleb assessment, and as you all know, TRAB is the most effective surgical method till now worldwide, and we assess the bleb based on the bleb morphology, and the main cause of bleb failure is scarring. And there has been different grading system, like the MBGS grading system, which sees the diffusion area, bleb height, vascularity, subconjunctival blood and all. Then Indiana bleb grade appearance grading system, Wurzburg grading system and all. In all these grading systems, they use the photographic appearance and the slit lamp to assess the bleb. The internal architecture of the bleb is not taken care of, and as you know, it's not easy to just assess a bleb based on the external appearance alone. So in these cases, along with this grading system, if you also use an imaging technique to see the details, you will get a better assessment of the bleb. UBM, as already mentioned by Dr. Jaini, all of them, It's a contact method and not usually used for bleb, especially as it's a post-op cases. It has a 91% sensitivity for predicting functioning blebs and 70% sensitivity in non-functioning, predicting non-functioning blebs. But because of the contact method, it's not very commonly used. The ASOCT can be used to assess the bleb height, wall thickness, and outflow pathway. And as you can make out, the outflow pathway consists of the sclerotomy or the internal ostium, the root under the scleral flap, and then through the edges of the flap into the subconjunctival space, and from there it's filtered into the tears through the veins and into the posterior episcleral space. So in the first image you can make out a sclerotomy. The second one, the root under the scleral flap is seen. Then there is some suprascleral fluid collection there. Then the subconjunctival fluid collection spaces are seen. And the next image is our own image, which also shows the root under the scleral flap and the subconjunctival and suprascleral fluid spaces. In case of cystic blebs, you can make out multiloculated fluid spaces. And the second one is an encapsulated bleb, where the bleb wall is having high reflectivity and no much of cystic spaces are seen. So it's not functioning properly. And a flattened bleb or a failed bleb, the difference in bleb elevation is difficult to evaluate, and there will be high reflectivity. There is scleral reflectivity along with the bleb area will be almost the same. This we can hardly make out the edges of the scleral flap. So microcyst in the bleb wall helps in assessing the functionality. In this picture, I hope you can see multiple microcysts. And this is anteriorly, actually, the bleb was having a good morphology, while towards the posterior aspect, there was an encapsulation. And when you take it, you can see that the bleb wall is having a high reflectivity there, which shows at that area the diffusion is not that good. So if the IOP rises, we may consider needling in those cases. And this, though the image quality is not good, I hope you can make out the sclerotomy ostium. And multiple subconjunctival fluid spaces are highlighted in the next picture. So the bleb after surgery goes through an inflammation phase, then a proliferative phase, and extended remodeling phase, and it takes about 1 to 2 months for a bleb to mature. And the importance of imaging is that when you do it at the right time and detect these changes, it may help us to assess about the intervention following the trabeculectomy, whether a laser suture lysis or a mitomycin injection or a needling will help or not will be better evaluated using these imaging technologies rather than just by a slit lamp or a photographic method. For single parameters, it is a microcyst which shows a good functioning bleb, and other parameters, as already mentioned, will help. And as already been discussed, I will just go through the slides fast. The tube patency can be checked with ASOCT. Tube block, partially blocked in the first picture through by an iris, and in the second picture, as already shown earlier by Dr. Jayashree, it's not entered into the anterior chamber. And even though the cornea is a bit hazy in this, and they suspected an endothelial touch of the tube, you can make out that the tube is not touching the endothelium. And as already mentioned, the UBM has a better penetration, and other uses are in opaque cornea. UBM has a better functional. The cyclodialysis cleft also has been mentioned, and I just wish to say that in this picture, the gonio may show a closed angle because the iris, as you can make out, not the ciliary body area, the iris is touching the scleral, and it may appear as closed. The scleral cleft, the cyclodialysis cleft may not be seen by the gonioscope. And malignant glaucoma, anterior rotation of the ciliary body can be seen. So plateau iris also has been mentioned, and I'll just rush through, and I think it also all have been covered. Thank you for your patient listening.
Just an announcement. I'm calling for the general body now in this hall because there won't be any quorum, so we will start at 5:30. You please continue. This has to be. This is a formality. You please continue. No problem. You can, okay. Thank you.
Thank you, Dr. Anjana, for such an illustrative presentation. So we'll have question and answer section also.
Can we identify pigment dispersion, that concavity, using ASOCT? Pigment.
Definitely we can identify the concavity, but we cannot identify the sonular touch. If concavity is there and pigment dispersion is there, then it indicates sonular touch, and that is the reason for